I've been doing this now for a couple of decades, and over the last 10 years or so, the options for treating women with breast cancer have really exploded. 10, 15 years ago, we were just introducing breast conservation, lumpectomy, and external beam radiation, and that in itself was a landmark advancement. And now, over the last 5 years, we've been introducing accelerated partial breast radiation, where women have an option for a 5-day treatment, in addition to the 6.5 weeks, or instead of the 6.5 weeks of traditional radiation. But women who are eligible for partial breast radiation need to be carefully selected so that we can obtain the excellent results we've had to date. So that things have become even more specialized in the field of radiation oncology for breast cancer care. So that I think being involved in programs that allow physicians to maintain that state-of-the-art, cutting-edge awareness of what's available as the field is changing so rapidly. Well, various validation studies are underway. There's a lot, as you're aware, lots of phase 2 data, which has shown equivalency now with up to 10-year follow-up being published by the earliest trials. But that's still a limited data set. The large national study is ongoing in this country. We're 3/4 of the way done. We expect to be finishing it in the next 2 years, B39. We have been participating, and fortunately many centers across this country have been significant participants in this study. So it's really been a national collaborative effort to collect the data for this validation. But these results have been validated in an Italian series using intraoperative radiation, but the same idea of limited field radiation after lumpectomy. And the Hungarian have a randomized trial that's validated the results as well, that's now been published. So we're seeing European data validating it, so we're anticipating that the US data will as well, but that data won't be available for the next few years. Well, I think we're still trying to figure out how that will play in the United States. There's different approaches that may work in Italy but may not work here. Some of the concerns we've had is irradiating a woman before we have the final pathology result. Knowing that, how do you define the field intraoperatively? You're not quite sure what you're moving in. There's some technical issues that we haven't become comfortable with here. Clearly the Italians have, and they have a very successful large series that is just starting to mature so that we can begin to analyze. But I think as that data matures, it will help us figure out whether that will integrate into healthcare in the US. Well, I think it fits in for a lot of different reasons, and certainly the acceptance by women has been overwhelming. When women have been given the option of 6.5 weeks of conventional radiation with lots of long-term data versus brachytherapy or partial breast radiation with not so much data and not so many women treated, they're still leaning in very large numbers towards partial breast radiation. And that's why the B39 clinical trial is so important, because if we don't do it now, it won't get done. The acceptance of this and the demand of this by the consumer, by the women patients, has just been overwhelming. So it's really been important to get the science behind it before it becomes commonplace. Well, B39 is comparing conventional whole breast radiation to partial breast radiation. There are many different techniques, 3 different techniques that can be used to deliver the partial breast. One technique is 3D conformal, where photons, a linear accelerator, is used to point multiple fields at the target to deliver the radiation. And the other 2 options are brachytherapy, where a little iridium source is used to deliver the radiation in and around the cavity. And that's a physician choice as to which technique that they want to use for that patient. It'll partially depend on what skills the physician has, whether they're comfortable with brachytherapy, and as well as what the patient wants. Do they want an invasive procedure? Do they want a less invasive procedure? So that we were able to, even within a randomized trial, still customize care a bit. Well, from a woman's perspective, if you have an early stage breast cancer and you're faced with, the decision making is, do you want to do a mastectomy or do you want to do a lumpectomy and radiation? The governor of Arizona, 4 years ago, 8 years ago, was faced with that dilemma, and she said, I'm a busy woman. I don't have time to go in for radiation for 6.5 weeks. I'm running the state. And she opted to do a mastectomy. And I thought, wow, that's really sad. Now, she had a type of disease that at that time we weren't considering it for partial breast radiation. And for her, that choice was good. And again, I think it's all about women having the ability to have good choices for their care. But partial breast radiation reduces the time requirements of radiation to 5 days. And we all take a vacation for 5 days, and that's all it really takes to get your full course of radiation in. The side effects are much less because the amount of tissue that we're treating is much less. And I always say we're targeting the area that needs it, and we're minimizing the collateral damage. So that its toxicity is much less than we have with conventional radiation. You know, the fatigue, the tiredness, that sort of stuff. Not that we don't really see much big toxicity with any of the techniques. So that patients have liked the fact that it's well targeted. We don't get dose to the heart. We have very minimal dose to the underlying even lung tissue, which we have much, somewhat higher doses with conventional radiation. So that, again, the acceptance by women has really been very successful. Both in terms of the time as well as the toxicity profile. So that when a woman's sitting there making her decision, all of a sudden now there's another alternative besides tying herself to radiation for 6.5 weeks. And again, we can't promise it before lumpectomy, but we can always say, go get your lumpectomy. We'll sit, look at the pathology, and then decide what results are best for you. So again, it's a lot of communication. And one of the things we were talking about is, why is this society important? These are the issues. Healthcare for breast cancer, optimal breast cancer care, really needs to be integrated. The surgeons, the rad-oncs, the med-oncs, the pathologists, the breast imagers all need to be communicating in the same language. In meetings like this, where we can start talking about high-risk benign disease, to treatments with the surgeons, to when does the radiation oncologist get involved, this is important information that each of us needs to know about our colleagues. And that's why societies that are working on integrating that information is really important. We all go to our subspecialty meetings. I go to lots of radiation meetings, but this is a very different meeting. This is the only meeting I go to that's truly integrated with the multiple specialties. And that, to me, really enhances my ability to deliver optimal care for my patients.